Hi, this is Terry, and I'm the founder and director of Deep Sea Foundation. Welcome to our educational channel where we talk about topics related to breast cancer and breast reconstruction. I'm joined today by Dr. Lauren Whipple, who specializes in microsurgical flap procedures for those affected by breast cancer. She's a member of a team of 9 other surgeons at PRMA, which stands for Plastic Reconstructive Microsurgical Associates, and that's in San Antonio, Texas. I am pleased to share that they practice the two-surgeon model there, where each patient who has flap procedures in breast reconstruction will have 2 microsurgeons in the OR attending to them. I've taken a keen interest in her interest in art, particularly anatomical illustrations, where during her medical school training, Dr. Whipple realized she could combine her artistic talent and now utilizes it caring for her patients during surgical consults. Dr. Whipple, welcome to the channel. It's high time I had you on. We've known each other a
Thank
bit.
you. It's so nice to do this finally, and nice to see you as well.
Yeah. So I'm going to let you screen share today because,
Awesome.
and while you pull that up, I just want to say that, Dr. Whipple, it appears to me, at least from my observation and from my own personal experience, breast cancer patients come into a consult either, it seems like, really frightened or full of information, depending on what kind of research they have done. So I know you have a unique way of guiding them through those consultations, and that's what we're going to do today. So I'm going to sit back, and my hope is, Dr. Whipple, by the way, I'm so appreciative of you doing this. I know you had surgery this morning, and so that means a lot to me. But my hope in doing this is really to empower those patients who may be a little bit shy coming into a consult or are overwhelmed with information. So I'm just going to sit back and let you take the helm.
Awesome. So thank you again for having me. I think, the number of new visits that I see in a week of breast recon patients, the common theme with all these women is it's a shocking diagnosis. It's a bit jarring to the body to even find out you have breast cancer and then make the decision, okay, maybe I need to go through with mastectomy. And your mind is fixated on those facts, and it's hard to wrap your mind around what does reconstruction even mean.
Mhm.
So when I'm seeing you in consult, I think it's important to kind of take a step back, take a breath together, and start from the beginning about what your reconstruction options are, and go over some drawings that are pretty basic that kind of guide what options you have in surgery so that we can make some, decisions together as physician and patient. So I'm going to go through kind of what a deep flap entails with my drawings, and this is what I do every day with my patients.
I feel calmer already.
Oh, that's so sweet. How do I go next here? Let's see.
Mm,
Okay. You
there.
see that okay, Terry?
I do. I love this illustration.
Thank you. Can you see my mouse by chance?
Yes, perfect. That's a
Awesome.
great way to use that.
Perfect. So the deep flap is, as you all or may already know, deep inferior epigastric perforator flap. So this is one way we rebuild the breast. I usually tell patients that starting out from the basics, we can either rebuild it with an implant or rebuild it with your own tissue. Rebuilding with your own tissue for the right patient is a really good option because it molds similar to breast tissue. It feels a bit more natural. It acts more like breast tissue in that if you gain weight, your body will gain weight. Your breast tissue, new breast tissue will gain weight. If you lose weight, same thing. So it fluctuates with your own body. So the deep flap is tissue that I use from the lower abdomen, from the belly button down, and it's similar to a tummy tuck incision at the end of the day. There
Mhm.
are important differences, though, that I think we have to really highlight to the patient when they come in and think they're just getting a tummy tuck. So, the final scar for a tummy tuck, the cosmetic surgeon, let me see if I can draw this, wants the scar to be down here. Okay. And the goal
Mhm.
of the cosmetic surgeon is to get that scar low so it hides in your underwear line.
Mhm.
For me, my goal is to transfer tissue from the belly to make a new breast that's nice and healthy and has good blood flow. So to do that, I have to capture blood vessels that live up by the belly button. So because I need to make an incision above the belly button, at the end of the day, I have to close from point A to point B. Okay. So that defines where your lower incision will go, some of the laxity of your lower abdominal tissue. So I think that's an important difference between the tummy tuck scar and the deep surgery scar. And you'll see that when you look online at some deep surgery scars. So that's one difference I like to highlight.
Mhm.
Another thing that I want to point out in this drawing, this right here is called your rectus abdominis muscle. So your rectus abdominis muscles, most people know as your six-pack muscle.
Mhm.
It's muscle that lives on both sides of your abdomen, and it gives you nice core strength or your ability to do a sit-up. So the deep flap surgery, the goal of the deep flap surgery is to really preserve this abdominal muscle. And my goal is to dissect out these tiny little blood vessels that's going to give this tissue new life as your new breast tissue while keeping this muscle in place. Okay.
Mhm.
So at the time of mastectomy, the breast surgeon will be working in the breast to take out your breast tissue. And the next question I usually get is, what incision are they going to make? And
Mhm.
I'll talk to you about that a little bit in my next slides.
Okay.
But while they're working to take out the breast tissue, I'm working in the belly to prepare this tissue, okay? And if you're getting a bilateral, I split it down the middle, and one side goes to one breast and one side goes to the other breast.
Mhm.
So although I'm pretty good, I'm not a magician. So what you have for your belly is what I have for volume to reconstruct your new breast, okay?
Uh-huh.
And then at stage 2, that's when we can play. We can make it bigger, we can make it smaller, we can have some alterations there. So after the mastectomy, that's when one of my partners comes in. So you made a good point that our group works as co-surgeon model. And I
Mhm.
think that's really important because it takes the operating room time down. We have a great team where all of my partners I would trust operating on family members. They're all so fabulous. And I think that's important because once your mastectomy is done, my partner comes in and he works on preparing chest vessels up here. So if you're wondering how chest vessels have anything to do with this, well, the reason is this tissue that I've removed from the belly here is going to rebuild your new breast here. So how do I get that to live? I'm not just taking out fat from the belly and just randomly putting it into the chest and hoping it's okay.
Mhm.
I'm connecting these tiny little blood vessels in the chest. And that's what the microsurgery part of it is. And so my partner helps prepare these vessels while I finish up the belly work. And then we work as a team to rehook up these vessels in the chest.
And
Now
that's when
this,
you're under the high-powered microscopes
right,
using,
right.
yes. Mhm.
And actually, I use loops, which are these
Mhm.
special magnifying glasses when I work on preparing this belly tissue here.
Right.
Um, and actually, in fellowship, I trained doing this micro part with loops,
Mhm.
which does have some benefit to it too. For me, I like that I know both ways. So if there's an anatomical difference in you where I need to move my head at a certain angle that's hard to do with a microscope, I have a backup plan and I
I
can move to my,
love I love that. I love
yeah,
backup plans.
yeah, you got to be versatile.
Yes.
Um, and so that's really the overview of a deep flap. I'm moving this abdominal tissue, and it's like a transplant where I'm disconnecting it off of the body and reconnecting it up in the chest to make your new breast. The difference with the transplant is obviously it's on a different person, right? I'm keeping it on your body. And that's really why our patients stay in the hospital. It's not because this is such a painful surgery, it's because we need to monitor that blood vessel connection.
Mhm.
And that's what we do for the next 48 hours in the hospital is make sure that there's good blood flow to the tissue that I've made as your new breast. Does that make sense? Was that good overview?
I'm like so impressed with this presentation. I love
Oh,
that you
thanks.
use the red lines to direct everything and how you do it. I do want to ask a question. I know the answer just because I talk to so many of you, but patients get concerned about that time frame where they get concerned about the flap monitoring and the viability of that flap. Because
Mhm.
I've heard some patients literally say, gosh, can my flap fail 6 months down the road? There is a time frame. Can you explain that to us, Dr. Whipple?
So when there are issues with the flap, I explain it as plumbing, really. It's like I hooked up a connection and there can be a kink in the plumbing. There can
Yep.
be stuff that forms as clot in the plumbing, so
Mhm.
plumbing's not working. And when there's an issue, it's usually within the first 48 hours. And I speak to patients before the surgery to kind of guide whether or not I would be concerned that something would happen, whether or not there's a high rate of miscarriages in the patient's history,
Mhm.
clues me into maybe there's some prothrombotic disorder nobody diagnosed you with. And those patients, I send you for a hematology workup to make sure that you don't have a propensity to clot after surgery. A
Mhm.
lot of the times it's not clotting disorders, it's just a kink or a twist that needs to be undone in the
Right.
operating.
Right.
Um, when things have settled in 48 hours, is it possible that there could be an issue 5 days later? Yes, but it's super rare. So rare
Right.
that, knock on wood, I mean, I haven't seen that. We do so many that my partners have, but maybe that day will come. I don't ever want to say that. So usually it's the first 48 hours, and that's why you're in the hospital. And
Right.
we're able to monitor it with special sensors that we actually put on the breast,
Mhm.
your new breast skin paddle. And so
Mhm.
I'll talk to you a little bit. I have some drawings on skin paddles, what that entails as well.
I'd love that.
Okay, let's see if I can go forward. So first of all, going back to incision pattern, a lot of patients are concerned about what their incisions will be. And it's really two factors, dependent on your anatomy and dependent on the cancer location. So I
Mhm.
talk closely with the breast surgeon to make sure they're comfortable with leaving the nipples. And that's what nipple sparing means, is leaving the nipple. And you get a great aesthetic result with this because it really looks like your own breast still after mastectomy. So this breast on the left, I just diagrammed underneath the skin here. This is the deep flap that I've hooked up to
Mhm.
new vessels. And right here, this is the vessels that live underneath your rib. So remove a small amount of rib cartilage. So I warn patients about this because sometimes they can have a little chest pain there
Mhm.
on their medial chest. And that's because I did a little work there.
Mhm.
So one incision pattern is to do an incision vertical along the lower aspect of the nipple and the lower area of the breast. And the reason why I like this is because in a woman that has lower hanging nipples, sometimes I'm able to keep the nipple and do what we call a breast lift at a revision. So a mastopexy incision, if this is your nipple, mastopexy, if I were to meet someone for cosmetic breast lift, the incision goes around the nipple like this, okay, and then down the nipple like this vertically.
Mhm.
So this incision over here, I'm making an incision vertical below the nipple with the plan that at a revision, I'll do a small lift to this nipple upward. So it
Makes
incorporates
complete
our
sense.
revision plan. Now,
Yes.
when our breast surgeon did the mastectomy, if this was your nipple here, you can see this drawn okay?
Yeah, I can.
So I had them do a vertical incision below the nipple with that plan.
Mhm.
Now, I don't then close this incision here. I leave a little bit of skin from the belly, and this is the skin that I monitor that blood vessel connection. So when you look back over on the left here, you see this shaded area here,
Mhm.
and that's the skin that I left from your deep flap transfer.
Okay.
So that's one way to do nipple sparing mastectomy. The
Mhm.
other would be a lower inframammary fold incision or a lower breast fold incision down here. And the reason why this one is nice is if you have great anatomy, meaning your nipples sit right up where they did when you were 21, they're right in the middle of your breast mound and where we all wish they would be, right? If that is the case, then I can make a lower breast incision here and just leave skin right down here where I'm coloring red. And then at the revision, I can take this skin paddle out and
Mhm.
you're left with a lower breast scar, and that's it. So when
Okay.
you look in the mirror, you barely see any incisions.
Right.
And that's when people say, the scarless mastectomy, that's what they're talking about.
Yes.
Any questions on that, Terry?
Um, I thought of one a minute ago. Keep going. Maybe it'll come to me.
Okay. This is a lot of info, so if you need me to slow down, back off, just let me know.
No, no, I'm going to get my pen out and start writing something down when you're talking. I'm so fascinated by this. What a
Oh,
beautiful
thank you.
presentation.
So this is a drawing I do regularly for patients to show them that it's possible to do a lift or a nipple lift at your revision surgery with a DIEP flap, not so possible with an implant, okay? So
Hmm.
the upper picture is the lateral of your breast, and this pink area here is what I drew to show you what your breast tissue is, okay? Your breast surgeon removed all that tissue and that all went away.
Hmm.
And then I need to work with what is left, which is a thin layer of fat here and skin. So it's almost a shell of
Hmm.
tissue.
Hmm.
And if I were to just put an implant in right where that X is, the problem is it would be hard to do a lift on this nipple up to the center of the breast mound, which is where I wish it would live. We all wish it would live,
Hmm.
because there's not many blood vessels giving it life. Because
Hmm.
all the blood vessels that traveled through this tissue to the nipple are gone.
Hmm.
So instead, if we're able to do a DIEP flap, the lower picture shows this pink tissue, which was breast tissue, was replaced with DIEP flap tissue. And this is your new blood vessel connection giving it life.
Now you've
So
got the blood source.
now over the next 3 months, when things heal, I have some inflow into this nipple. I also have no foreign body that I'm concerned about getting exposed if we have a little healing issue with the nipple underneath. So I'm able to do that small lift to the nipple that we talked about.
Mm.
And that's why when I see patients and they're kind of on the fence between implant and DIEP flap, and their nipples are not right at where they were when they were age 21 and they need a little lift, I think, this could be the right fit for them then.
I think there's so much to be said too for how much patience it takes to let your body heal because
Yeah,
this all makes complete sense. I always tell
totally.
patients that, you just have to be patient with the healing process because in the end, it's going to benefit you during phase two.
Totally. And
Yeah.
because, a lot of women are healthy when they get this diagnosis and they're on this go-go mode, especially today's day and age, it's hard to press stop for your body.
Yeah.
Um, but you really need to.
Yeah.
And I tell
And you're
patients,
not really pressing stop. You're
right,
slowing your body down to allow it to kick in and heal.
right, which
Yeah.
is a lot of work.
Yeah.
So I tell patients it's about 4 to 6 weeks healing time for this deep surgery. Um, and to go slow with your body, to listen to your body, especially the first 2 weeks while incisions are nice, are fresh, and everything's healing.
Mhm.
Past 2 weeks, you can start to, if you need to reach your arm a little bit more, okay, fine, but no exercise or anything till you're healed,
Mhm.
at least 4 weeks.
Yeah,
Um, and that time is really important.
it
Also
is.
to reflect what you've been through. This has been a huge trauma to your body.
Mhm.
Um, so let's see what I have next. Oh, so this is for a skin sparing mastectomy. The term skin sparing means that the breast surgeon is leaving all of this native breast skin here, okay? But what they are removing is your nipple areola complex
Mhm.
with the breast tissue underneath. And for more access, depending on the diameter or the shape of your nipple, sometimes I have to extend that incision vertically underneath the nipple for the breast surgeon. And they remove all the tissue. And then when I put everything back together with your DIEP flap tissue, sorry, I do that by leaving a skin paddle, this orange skin paddle, in
Mhm.
the shape of the diameter of your areola to then rebuild it in the future.
Yep.
And I think that's an important distinction for patients to understand when we're taking the nipple. It's jarring at first, I think, for women to look in the mirror and see just a circular blank skin paddle. It doesn't really feel like a breast to them because it's just a circle that is skin from the belly, and that can be very weird.
Yep.
However, with rebuilding it, the pictures below here, this is how we rebuild that areola. I leave a diameter that's a little bit larger than the areola I would want as final because I make incisions here to then elevate. So this is called a CV flap. I can then elevate these little pieces together and turn them in to make a nipple that's projected.
Mm-hmm.
And then we do 3D tattooing. And honestly, at the end of the day, your primary care doctor could stand at the back of the room and look at you and be like, wow, you didn't have any, you left your nipples, huh? It's amazing what we can do with
Oh,
reconstruction.
it is. Medical tattoo artists these days are doing,
So talented.
oh, they are. They are so
Yeah.
talented. Yes, it's a bit like origami for you, isn't it?
Yeah,
Yeah.
totally.
Mm-hmm.
And I do warn women though, because there's some women that, have lived their whole lives with larger breasts and they love all of a sudden not wearing a bra because maybe they're a bit smaller and they don't have any projection to their nipple. So they love going braless. And I say, if you want to go braless, that's awesome. You do you. Just know that you may not want to if I make a projected nipple.
Right. Headlights on, headlights off.
Exactly. They do go down over time. They shrink
Yes,
down a bit, but
of course, swelling just the nature of the tissue.
yeah.
Yeah.
And then the last picture I have is about radiation. So
Mm-hmm.
I think skin paddles, it's hard to really understand what your skin paddle will be if you had radiation.
Mm-hmm.
And a lot of patients we see from out of state had their mastectomy in the past, had radiation. Radiation is like a really bad burn to the body. And that burn develops not just when you stop radiation, but again over the next 4 to 6 months. So we really let that full burn develop over time and your tissue heal from it before we pursue any reconstruction. And when we do pursue reconstruction, I have to then expand this breast pocket here to make a new breast to fit the other one if it was unilateral or one-sided. So how do I expand this tissue that was removed from your mastectomy because you were closed flat and your breast surgeon took all this skin away?
Mm-hmm.
So things are tight. And the way that we do that is by leaving abdominal skin. And we leave more abdominal skin than you would see in an immediate reconstruction, or immediate meaning reconstruction at the same time as mastectomy.
Yeah.
And I think for women, this big scar can sometimes be a lot to swallow. And scars fade with time, and the shape is what really gives you a great aesthetic result in the future.
Mm-hmm.
Um, and I trained at UPenn on the East Coast, and actually at UPenn, we radiate flaps.
This
And
is a good question. Somebody
yes,
just asked me this morning on our Facebook page. I'm so
yeah.
interested in this.
So
It's
this
a
is a
huge concern.
hot topic.
Yeah.
When I was in fellowship, I probably did maybe 5 delayed reconstructions, delayed deeps.
Mm-hmm.
I was doing at least 3 a week, more than, a ton a week,
Mm-hmm.
but all of them were immediate because we would radiate the flap. And so I was able to see these patients at follow up and see the changes to the flap. And I was actually very impressed with our results and how good the aesthetics were with radiating the flap. And that's having close, communication with your radiation oncologist. It's understanding what they're doing to the tissue. It's understanding also the mindset of the patient is really important. And, do they just want to be done? They just want to not even think about recon. They're not there right now. And that's fine. We can always rebuild. Um, but it's now a conversation that I'm having here. And when I moved here almost 2 years ago now, I can't believe it's been that long. I said, I'm going to radiate flaps. And everyone said, oh my God, you're crazy. Um, I'm radiating flaps and I'm getting some great results. So you just have to have close communication with your oncologist and radiation oncologist and the breast surgeon. And we all need to get in the same room and understand and all have the same goal.
I have
Um,
I have goosebumps right now. I
aw,
just I can't emphasize enough that coordinated care.
right.
And patients sometimes have to drive that. Sometimes they have to say, look, especially if they're out of state or coming in to see
Oh,
you,
totally.
Yeah, coordinated care is so very important.
Yeah. And when you look at results for delayed reconstruction, what I tell patients when they're debating whether or not they want to delay it or not, a lot of the times, if you look at this drawing down here, the reconstructed breast will always have asymmetries between the two sides, your natural one and your reconstructed radiated side, because the lower inframammary fold here is really important. And a lot of times it's shrunken up on the radiated side, and we have to really inset or place that flap tissue low to match the other side.
Mm,
But because this whole skin envelope is different than this one over here,
mhm,
you'll have significant asymmetry still possibly between the two sides.
mhm,
So it's possible that someone who needs radiation with the right anatomy, I'm able to actually leave the nipple and them get radiated, and they may have a smaller breast, but then I can go chase that at a revision. But then we left the nipple, and maybe it was less traumatic for the patient to go through that radiation completely flat, and we left them a, breast reconstruction that they're happy with. So I think there's asymmetries both ways. You just have to have a really good relationship with radiation oncology and be talking to these people all the time,
mhm.
uh,
It's
and take
changed so
ownership.
much over the years too, the targeted therapies
Totally.
that they're doing now and how they're, setting that up prior to radiation for patients. And
Right.
I do feel too, Dr. Whipple, that patient expectations need to
Hmm.
be discussed and kind of fleshed out in a consult. Because honestly, before any of us had any kind of breast cancer or breast reconstruction, our breasts were not completely symmetrical.
Exactly. Yes. And I do talk to patients about that. I point out very regularly little asymmetries, and I always say, I'm not sure if you notice this. And they're like, oh, yeah, you're right. I never noticed that. Um, but I think some good key points to think about before your breast recon consult, some things that people have a hard time wrapping their mind around or understanding, that you can get lost in the details online with. Um, so hopefully that was helpful.
It was so helpful. It was so helpful.
Good.
I think that we have to emphasize to patients, if you're done with your slides, you can stop screen sharing now too,
Oh,
and we'll
awesome.
wrap up our conversation. But I think that it's very important for patients. I've said this before in interviews. Um, honor yourself and give yourself a little bit of time to do research. But when it becomes overwhelming, take a step back. Just take a
Right.
step back and take a breath, because it can become overwhelming. And in many instances, we don't have to rush these things and make quick decisions. There are instances where, decisions have to be expedited, but know your tumor biology, know what kind of breast cancer you have, and ask that question: how much time do I have to research this and really,
Mhm.
find out more before I come in for my consult? This was huge today. I can't
Yeah.
wait to share it
Yeah.
and to just let patients watch it and absorb it.
Yeah, awesome. I'm so happy we did this. I think it's, great education. And I know that this is a really overwhelming time.
Mhm.
And these pictures even can be overwhelming to look at. But what I would say is, you don't need to feel rushed in a consult. You can just sit with all that information and say, I need to take a step back. I need to think about things and give yourself a timeline. By this date, I'm going to make my mind up. And ask if that's okay. If it can we wait maybe a couple days? Is that okay for my cancer? And I'm sure it is. Give yourself 48 hours, relax. I tell my patients, go have a glass of wine. Just you don't need to make your mind up today.
You know what? I love it that you said give yourself a timeline. I just listened to a podcast on the elliptical the other day about time boxing, and that's not this kind
Mm,
of boxing. It's actually saying to yourself and giving yourself a date. can I get back to you with my decision in 2 days or on March 30,
Right.
whatever. It's if you give yourself that date and that time, then you're giving your own self accountability for the decision too.
Totally.
So, yeah.
Yeah.
Thank you
Awesome.
so much. Thank you for the work you put into this. Thank
Of
you for
course.
all the education you provided today. And it was so good to see you.
So good to see you. Have a good day, Terry.
All right. Thanks so much.